Good afternoon, everybody. Thank you for joining us. This is Jeff Adest. I am on today with Sandy Jensen. I feel like it's unfortunate that you have to be listening to us today about this topic because it seems like something that should be pushed off. As you're probably seeing in the rest of the world, most enforcement agencies are pushing off deadlines. IRS pushed off deadlines. OIG has said they're not going to be doing investigations. Most state agencies have said they're stopping investigations. But for whatever reason, HRSA has decided that the deadline for the FTCA application is going to stay in place. For those of you who attended the webinar last week, you know that we spoke about that we had emailed HRSA to try to convince them to push off the deadline, and they had said no. And since then, they have now issued a formal FAQ saying they will not be pushing off the deadline. So I guess, I don't like to criticize anybody, but what they're saying to you is instead of dedicating all your resources, take care of all these patients who are dying or sick or trying to prevent from dying, you're going to have to use some resources to deal with completing a complicated FTCA application and doing all the things that are required, in order to be able to submit the application. The application itself is not so terrible, but a lot of the things that have to be done in order to submit the application will require significant efforts over the next month or so. So just so we don't get this question a million times, the slides and the presentation is being recorded and will be sent out in the next day or two. The slides will be sent along with it, so you do not need to sit there and take pictures or worry about that you're not going to be able to follow along. All the slides will be coming. So the application can be submitted starting on April 13th, and it must be submitted by May 14th. Right? So then, as in years past, there's a separate application for the FQHC and its employed physicians and some of its contracted physicians, but volunteers are a separate application which you would have to submit also by the same date. Now, we are going to walk you through everything that you need to do in order to comply with the application, but I will tell you at a high level, it's probably 90% the same as last year. However, unfortunately, the 10% that changed will cause some problems or will cause some additional work for you because you have to be doing certain things, again, which they didn't tell you last year that you had to do, and kind of like last year where a month before the application was due, they told you there are things you had to have been doing for the last year. They've now done the same thing again, and they've added some things that need to go into your board report, which were not required last year, which you now will need to do as well and somehow get done essentially in the next month, right? Most of you between now and May 14th probably have only one board meeting, maybe two, and so you're going to need to make sure that you dedicate a significant portion of that board meeting, which probably or hopefully most of you are doing by phone now and are quicker meetings. So you're actually going to have to make the meeting longer to deal with all the FTCA requirements. I will also mention that historically many of you reach out to us to help with the applications, and we're very glad to do that. I would tell you again, understanding everything I just said about the coronavirus, that you should try to reach out to us as soon as possible because, like everybody else, we are working remotely, so it makes it a little bit more difficult to work. And number one. Number two is, like I said, because there's probably only one board meeting, you need to get it done quickly so you have it prepared for the board meeting, and there are reports you're going to have to do in order to be able to present to the board. So Sandy is going to walk you through the specifics, but I just wanted to talk about a couple of high-level things before we get into the specifics. First, we had a webinar last week, and if you missed it and you wanted us to send you the presentation or the recording, please let us know. But we went through telemedicine issues last week, and as part of those issues, we addressed some things relating to the FTCA, And kind of like last week, for those of you who are on, you may remember that literally during last week's webinar, Medicare came out with some new rules that I was able to read as I was talking to you and present to you. And so today, HRSA came out with something new after we put everything together. It's not as significant, but it is important for you to know. So just to go over for 2 minutes, we talked about that FTCA coverage applies if you're doing telehealth, as long as it is a patient of the health center, either a pre-existing patient or someone else new coming in to become a patient through the telehealth visit. We also talked about that telehealth is not a separate category by itself on your Form 5A, but rather whatever underlying service you're providing by telehealth has to be on 5A, and telehealth is just a means of delivering, so you don't need to change your 5A for it. We did talk about as well that you need to document, even when you're doing it through telehealth, you still need to document and chart like you would for a regular visit. Obviously, there are certain things they're not going to be doing, right? You're not taking the person's height and weight when you're doing telehealth generally, so that wouldn't have to go in, but you do need to document. I should mention, and there's no way we could do state by state because there's people on from many different states, but in certain states, the state themselves has pulled back on some of the requirements relating to documentation and said that as long as you have some basic documentation, you're okay. Our recommendation is still to do full documentation because not necessarily has every state done it, and not necessarily has any payer agreed with that. So we still think you should be documenting and coding, the way you normally would. One of the things that came out today that expanded coverage somewhat is there was a letter that came out from Jim McRae today from HRSA, basically saying that beyond the FTCA coverage that you have for patients of the FQHC, if one of your doctors is providing services to a patient specifically COVID-19 related, right, to prepare, prevent, or respond to the person having to treat them, and it's done through in-person or telehealth in your community, even though it's not your health center's patient, there will still be FTCA coverage for that because an emergency has been declared. So again, just to go over that again, because this is not in the slide, if there is a COVID outbreak in your area, which in many states that is the case, and because of that, your physician is asked, when I say your physician, I mean your provider is asked to assist with COVID-related issues, even for patients who are not patients of your health center, right? They're pulled in by the local hospital, or they're pulled in by some other resource. Whether it's in person or through telehealth, there will be FTCA coverage for it. But again, that's only limited to COVID, and it's only during this emergency period. So if the doctor is asked to treat a patient, and in the course of treating the patient realizes that the patient does not have COVID, the doctor cannot continue treating that patient and be covered under FTCA. There would need to be some separate insurance for that. In many states, the state has actually issued a blanket immunity for people treating patients as it relates to COVID, but not necessarily, again, as it relates to other things. So if your doctors are being asked to go to hospitals, and we're starting to see that, again, they can go to hospitals, but only to treat the COVID patients. If they're treating other patients, then unless your state has issued an immunity, there will still need to be some other insurance in place to deal with it. The other thing I just wanted to point out in turning back to the FTCA application is that unlike in years past, where you just had some minutes showing you did QA from whenever, anytime in the last 2 years, everything this year that you're submitting has to be documentation of things that were done within the last 12 months, not things that were done before. So if it's before, whenever you submit the application, assuming you submit it May 14, 2020, anything that was before May 15, 2019 would not count for most of these purposes, which is why I said that you might have to do a lot of significant things. Like if the training more than 12 months ago, that's not going to count. You're going to have to redo the training. Also, we are, in going through this, you'll see, and yes, let me just state again, the slides will be made available and emailed out to you. But in going through this, what we have done is, for each of the elements where something is brand new, we have put the brand new piece in red so you could follow. So if you're going back to your last year's application, you can see what is new and different than last year. So like I mentioned, there will not be an extension as of now. I don't understand why NAC is not fighting this and pushing it, but there is not as of now. And if you have volunteers who were not included on your redeeming application and who come in after, then beginning on June 5th, you can submit additional applications for them. With that, I'm going to turn it over to Sandy to walk through the specifics.
Okay, great. So just as a refresher, the Federal Torts Claims Act just provides malpractice coverage for any claim brought against an FQHC that is deemed a federal employee under the Act. Employees of eligible FQHCs may be deemed federal employees and are qualified for the protection. So it would be the health center that is covered and also their employees. And so the huge benefit of that is that you're immune from medical malpractice lawsuits. The action is actually against the federal government, so the FQHC is not even, or the FQHC employee is not even named in the action. And compensation for any personal injury is the responsibility of the federal government and not of the FQHC. So as we're all aware, every year you have to submit an initial and then an annual redeeming application. In some years, as you may recall, you are required to put a very detailed answer with respect to all of your policies and procedures. You have to list them out and explain in detail how you met quality assurance requirements or how you met risk management requirements. And this year, like last year, the application includes many yes or no questions. So, do you have a QA plan or system-wide QA policy, yes or no? But, it's easier to complete the application, but you have to remember that you have to actually have policies and procedures backing up those yes or no responses. So if HRSA comes in and does a site visit, they'll require you to submit your policies and procedures, and they'll look through them carefully. But then they'll also make sure that you've implemented them. And that's, they go through and they ask staff questions to make sure they understand what's in the policies and procedures. So you really have to be implementing them, and you really have to have policies and procedures that comply with all the requirements. So like last year, the FTCA application is broken down into 4 sections: risk management, QI, QA, credentialing and privileging, and claims management. And like last year, you have to disclose whether you have any active conditions. And this could be a basis of disapproval of the deemed status. So if you have any active conditions, we really have to try to address them now so that they don't impact your application. And like last year, it has to be signed electronically by the executive director or CEO. So risk management. So you have to designate a risk manager who's responsible for overseeing the risk management program. And this person has to take annual training. And HRSA explained that they want to see a progression in training. So you can't have your risk manager always take level 1 ECRI training. They would want to see level 1, then completion of level 2, and then I think ECRI added also a level 3. And this year, again, like last year, you have to upload evidence that the risk manager completed training in the last 12 months. So again, as Jeff was saying, look at the date of the training. It has to be a year from the date of submission, or within a year from the date of submission. You also have to upload the risk manager's position description, and the position description must include risk management activities. So sometimes the risk manager is just added to somebody else's title, but then if you look at the position description, it doesn't say risk management in any of the duties. And so that's a basis for them to disapprove or raise issues about the application. So make sure the duties include risk management activities. Also, the FQHC has to attest that it has a risk management program. And the program is just a system-wide effort or plan to address risk management across the full range of FQHC activities, including with respect to patient management. And those topics include triage, scheduling, missed appointments, intake, and tracking and follow-up. And so for most of these, you wouldn't think that you would have to have like procedures in place if something happens, like missed appointments. They want to see more than just you maybe noted in the patient record. They want to see that your health center has a plan in place where for some patients you might follow up on these missed appointments. Also, with respect to patient management, the FTCA site visit protocol excuse me, requires that a health center submit written policies on these activities, including phone triage, no-show appointments, urgent care visit, and walk-in patients policy. So you have to have policies that allow for no-show appointments and follow up on these no-show appointments, and allow time within the schedule for patients who walk in or have an urgent need to be seen at the same day. Your risk management program also has to include risk management training and completion of quarterly risk management assessments and annual reporting to the board. Your annual report to the board. Now this one is the one that usually requires a lot of work. It has to be a detailed report, and it has to include risk management activities that have been conducted during the year. And some examples are projects or assessments, the status of FQHC's performance relative to risk management goals, and what HRSA really wants to see is data and trend analysis, including with respect to adverse events, patient satisfaction, other risk management data points. They love graphs. So to the extent that you can see or display a graph showing maybe, whether incidents in a certain area, like needle sticks, whether they've increased or decreased during the year. Those are the type of things that HRSA wants to see going to the board. They also want the report to outline proposed risk management activities for the next 12 months that relate to high-risk areas that FQHC has identified. And new this year, they also want the report to include other topics such as risk management assessments you've done, the trainings that you've completed through the year, incidents and procedures. So again, this year you have to submit your referral tracking policy, hospitalization tracking policy, and diagnostic tracking policy. There haven't been huge changes in these areas, but again, these are big areas for HRSA, and they want to see that you have policies and that you're implementing them. For hospital tracking, they want to see that your policy contains the following information and that you track this information. And in particular, in relation to a site visit, if HRSA came in and did a site visit, they would want to see that on any given day, somebody would be able to identify patients that have been sent to the hospital by the FQHC, the reason, and any documentation received or requested. Now, one thing we wanted to point out, this year's PAL, like last year's, described the hospital tracking policy as policies that included procedures on hospital admissions ordered by the health center providers or initiated by the patient. So the compliance manual made clear that you no longer had to track hospitalization of when they were initiated by the patient. So we reached out to HRSA last year and said, this isn't a requirement anymore. Why are you requiring FQHCs to track this? And so they agreed, but this year, again, they included this language. But again, it's not a compliance manual requirement.
Right. So just a couple of things about this overall. So I should have mentioned this at the beginning. There is what you need to do to comply with the application, and then there's what you need to do to live in real life. And for purpose of the application, you need to have all these policies in place. You need to have, tracking logs and all these kinds of things. However, we've gotten this question many times, and I know as an attorney I probably shouldn't say this, but I feel like I need to say it. Right? If your choice today is between taking care of more patients who are sick, and given the epidemic that's going on, and worrying about hospital tracking, I think that it's obvious to everybody to take care of the patient. So for purpose of the application, you need to be able to show that you do this. You don't necessarily need to show that you're doing it specifically on March 31st or on April 5th, or any time now during this with the craziness that's going on. So don't walk away from this saying that we need to do every single thing we're doing. For those of you who were on last week, I said in last week's webinar as well, patient care has to come first, always, but specifically now, patient care has to come first. So if you can't doing all your regular QA and risk management activities that you normally would do, during these couple of weeks or however long this lasts, that's fine. You still need to be able to show her so that you have the policies in place and you do it for overall, FTCA purposes, and you still need to have the board report because we have to submit those. But it doesn't mean on a day-to-day basis that you need to be doing everything that you normally otherwise would be doing from a back office standpoint. Also, as Sandy mentioned, what they seem to have done this year is, if you remember, we did a webinar a few months back talking about if you have an FTCA site visit, they've pulled in this year in the application some things which were part of the site visit guide, and which I think we had mentioned back then we thought they would pull in. So, while you might want to go and scream to her so that, you never told us we have to do this, on some level they're going to say, well, we kind of hinted it to you in terms of the site guide application. Okay, Sandy, go ahead.
Okay, great. So the next policy that you have to submit is the referral tracking policy. And again, this hasn't changed from prior years. The policy generally has to include some elements, and that includes defining the referral type, whether specialist referral or a patient-initiated referral. During the FTCA site visit that we were a part of, HRSA clarified that they want the policy to include a discussion about urgent referrals versus routine referrals. So with urgent referrals, the thought is that there's a different time period for requiring the report back from the specialist, or maybe the procedure is different for urgent, where the health center would assist the patient in making the appointment for those. Okay, sorry. So the elements for referral tracking are listed, and your tracking policy must also include how to document in the patient's medical record for follow-up efforts, missed referral appointments, how many attempts will your staff make in trying to obtain documentation from the specialist, and what methods will be used. So the third tracking policy is diagnostic lab test tracking. And
well, actually,
this is a really...
I'm sorry, Sandy, before you go there, just going back to what Sandy was just talking about on the referral policy. So this was a very big thing for HRSA because they want to make sure that if you think the patient really needs some service, that you're really following up to make sure they're getting it and you're not just leaving it up to the patient. And during the site review that we experienced, they were really hyper focused on it and wanted to see logs and wanted to see policies around it. And basically the idea is that if you think the patient is really sick, and the same thing can come up now with regards to lab testing or things like that, if you get a lab result back and you think the patient is something really wrong with them, you can't just rely on the patient next time they come back in a month to follow up with them then. That you have to have some process to follow up with them more immediately.
Yeah, and they've also added risk management training in this area too, because it's such a high priority for them, and we'll get to that in a few slides, but this is really critical. And if they come in and speak to you, they're going to actually talk to your staff and have them walk them through a referral, or walk them through a lab order from start to finish to make sure you have all the correct elements in place and your staff are on top of everything and understand the policies and procedures. So there's certain tracking elements that are required in your policy. The patient information, date the test was ordered, who the ordering provider was, and the other elements listed. So your tracking policy has to define normal, abnormal, and critical values, and the time frame to communicate the results. Jeff and I are never popular when we say this, but all results have to be communicated back to the patient, including normal results. And this was a big deal for them as well. And other issues to address in your policy is how you communicate the results back, and what would happen if the ordering provider is on vacation or is not available on the day the results are back. Do you have a process in place where a backup provider is responsible for obtaining the results and communicating them to the patient? And again, I think the concern here is with a critical result. Even if the ordering provider is out for a day and a critical result comes back, how will that be communicated to the patient? So the 2021 application requires FQHCs to attest that they have implemented risk management operating procedures. So the program really is the overall system for your risk management activities, and operating procedures are how you're going to implement it. And your procedures have to include identifying the areas or activities of highest risk. So it could be just by the very nature of the services you provide. So for example, OB procedures or dental procedures, because of infection control issues, that could be an area of highest risk, or OB is usually an area of highest risk. So you have to identify these areas and then put in place procedures to try to mitigate those high risk areas. And you do that through establishing clinical protocols and supervision. So your operating procedures also have to include documenting, analyzing, and addressing complaints and near misses. And this year's PAL also added sentinel events, which are usually events such as like death or injury, could be brain injury that was unexpected. And so one point about near misses, usually when we talk to health centers, we'll say how many near misses were reported, and it's usually 0 or very, very low. So they want to see that you're making an opportunity to identify these near misses and then taking action to mitigate any risk in the future. Operating procedures also include...
I'll be a little less nice than Sandy. If you don't have any near misses at year end and they come and do a site review, they're not going to believe you. right? If you're, so I guess I should break it down, right? If you're a small center and you see the total of 3,000 visits a year, you might not have the same issue. But if you're a large center and you have 7 sites and you do 100,000 visits a year, the possibility that you never had a near miss is extremely unlikely, right? So a near miss could mean, right, and if people think of a near miss being as something that's crazy, like in the hospital you almost operate on the wrong leg. But a simpler near miss could be you have a doctor who's about to prescribe a prescription to somebody and realizes that that's going to be counteracted by something else the person is taking, and says, okay, I'm not going to prescribe this. I'll prescribe something else. That's a near miss. That's something you should document. Another near miss could be that you had 2 John Smiths and you almost treated the wrong one, or you followed up with the wrong one, or something like that, right? Or it could even be in the context of something that would come up like a HIPAA issue. You were about to send patient records out, you almost sent out the wrong patient's records, and you caught that before you sent it out. That's also a near miss. So, I mean, in real life, right? People they mess up once in a while, or either they do mess up or they almost mess up, right? No one's perfect. And one of the things we do when we do FTCA training for providers is try to explain to them that although a person's natural inclination when they screw something up is to try to hide it and hope no one will ever catch it, from a HRSA perspective, we actually want those things to come forward, right? And for us to be able to document that it happened or almost happened, what we're doing to fix it. And so HRSA is really looking for those things. I will tell you that the center we were at when we sat through the FTCA review was a large place, and they had 3 or 4 near misses, and HRSA was surprised at that number being very few for a center that was that large. So they want to see some of these, and I encourage you to encourage your providers to come forward with them. And even if you fix it, because right, you think about it, we fixed it, we don't have to worry about it. Get it into your QA and risk management minutes and meetings so that you have a record of it to be able to show her so that you did
it. Okay. And the same goes with complaints too. Complaints and grievances. Sometimes we'll say, show us your complaints and grievances, and in the entire year there was not one complaint or grievance, which again, similar to near misses, seems inconsistent with usually the size of the health center and the number of visits provided during the year.
Right.
So you're
and just on that point again, because this comes up a lot, in our risk management training. So there's a formal complaint versus an informal complaint, right? Every center has, on any given day, someone comes to the front desk and complain, I've been sitting here waiting for 45 minutes, and how come that person went ahead of me, and things like that. And so those are the kinds of things which you typically will handle in an informal way, and hopefully the site manager or someone at the front desk can calm the person down. And we're not saying, again, living in real life, we're not saying you need to document all of those. But I guess the rule of thumb is if something comes up which can't be handled immediately, that requires follow-up or requires a higher up to get involved, even if it's not a formal thing in writing, right? Because it used to be that patients would write letters and writing, incidents. And if you have that's great that you have them. Great from a HRSA perspective, not from a real life perspective. But great you have those documented. But if not, you need to think about taking some of the other ones, which you still handle verbally, and converting those into incidents that you could now go back and report at your QA meetings, because even more than the near misses, if you go through a year and you have no complaints to show HRSA at the end of the year, it would surprise me if they do not remove your FTCA status if they have a review of you, because it's just not possible.
Okay. So other operating procedures include setting and tracking risk management goals. So your goals, it's always an effort to try to come up with with goals that are achievable and do this on an annual basis. But some that you could consider are looking at your patient satisfaction reports and finding ones where, you know, they're lower and you're trying to increase satisfaction in that area. So, for example, wait times, or with courtesy. If your satisfaction is low in courtesy, one of your goals could be increasing satisfaction in that area. And then you would track your progress related to those goals. So you would continuously look at your patient satisfaction and see how your numbers went up or down in that area. You also have to develop and implement an annual healthcare risk management training plan, and you have to submit that as part of your application and completing the report. So with respect to training, 2 new training requirements were added. One is on medical record documentation, and for the FTCA site visit, they spent a lot of time looking at medical record policies and procedures, and that included like archiving, medical record completeness, how things were documented. So they want a training in this area, and also follow up on adverse test results. So your staff will have to be trained as part of risk management training on following up on adverse test results, including the policies and procedures. So they want to make sure that staff are aware of their responsibilities. Like last year, you have to provide obstetrical procedure training, including continuing education for electronic fetal monitoring and dystocia drills. And even if your health center doesn't provide labor and delivery services, but provides prenatal and postpartum care, you'd have to provide obstetrical training as part of the risk management training plan.
Right. Now, with regard to all this training, just something to think about, right, is you basically have a month to get this done. And if you haven't done some of this training, how am I going to get it done in a month? So I would say that if that's an issue for you, please reach out to us, and we have some strategies for you. And we also have training materials available that you can use, because, you know, just going back to the prior slide, right, some of those things, if you didn't do training on medical records documentation, you might say, well, a provider's been there for 20 years, they know how to do that already. That's I agree with you, they probably know how to do it, but HRSA is saying we want to see documentation that you did that kind of training. So we have some ideas for you relating to that.
Great, okay. And similar to last year, you have to do infection control training on the topics indicated. This year, together with HIPAA, you have to also train on other applicable medical record confidentiality requirements. And that would be something that's required under your state. For example, in New York, you know, probably nationwide, there's specific confidentiality requirements related to substance use disorder treatment records and in some cases mental health records. So they added that as a new requirement to just highlight that HIPAA is not the only medical record confidentiality law that your staff should be aware of. And once again, the risk management training plan has to include specific trainings for groups of providers that perform various services that could lead to risk. So it's your dental providers or your pharmacy providers or your internal medicine providers that render patient services that could lead to risk. So you have to make sure that your training plans include all of those training courses that are required. They want to see all of the training courses listed out in your training plan. You're also going to have to upload your training documentation methods and tools. So in prior years, they were looking for your tools. So that could be a blank sign-in, sign-out sheet or an Excel spreadsheet that had listed your staff and the required courses and, you know, date that they would take it. But this year they specifically said we do not want blank tools. We want a fully completed training and tracking documentation. All documents have to be from the last 12 months, as Jeff had mentioned earlier, and any documents outside this period won't be accepted. So sometimes we see, when we talk to health centers, we see that they provide all the required courses, but they don't have proof that staff attended and completed the training. So you really have to have documentation. You have to have some process where you're documenting that staff actually completed the training. And then training has to be part of performance reviews and credentialing and privileging. You have to be able to identify those staff that haven't completed training and then have a process in place to get them to complete the required training. And then you also, as I had mentioned before, you have to upload proof that the risk manager had completed their risk management training in the last 12 months. Risk management assessments are another key area of the FTCA application, and they're looking for quarterly assessments that include any data or trends. They could be through reports or risk management committee meeting minutes. And this year, they have to be reflective of the last 12 months. So you have to prove that you have risk management assessments completed for the entire 12-month period. So what are some of the governing board requirements? They have overall responsibility for risk management. They authorize the risk management plan. They receive the annual risk management report, and they should discuss it. And if they have any comments, it should be reflected in the minutes. They make any recommendations for follow-up. And then the health center has to follow up according to the board's recommendations. As part of the FTCA application, you have to upload proof that the board received the annual risk management report, and that could be through meeting minutes signed by the board chair or secretary. So moving on to QI/QA, there weren't really many changes from this year's PAL to last year's. You don't have to upload your QA plan, but again, you're attesting that you have it, and you have to make sure that you have one and you are implementing it within your health center. Your plan also has to include procedures that address adherence to standards and identifying and analyzing patient safety, adverse events, and follow-up actions. Your QI/QA operating procedures, the 4 bullets under this heading are really important, and HRSA really takes a close eye on this. You have to have a process in place to obtain patient comments or assessing patient satisfaction. You can hire an outside company that comes in and makes calls, or you can send out postcards. Any way you do it, you have to have a process in place to get patient feedback. Then you collect it, you analyze it, and you determine where improvements can be made. The same for patient grievances. They want to see a formalized process that allows the patient to submit a written or oral grievance. You have to complete periodic QI/QA assessments. And in later slides, we'll talk about this more, but what they're really looking for here is a peer review type process. And you have to produce and share reports on QA to the board and key management staff. So again, you have to upload your QI/QA assessments, and that could be through reports or committee meeting minutes or actual assessment documents. And they have to be reflective of the last 12 months. So again, you have to submit enough QI/QA assessments to show that you've done them throughout this last 12-month period. And they're really assessing provider adherence to current standards. And again, that's usually done through peer review, and identifying any patient safety or adverse events. So QI assessments, they have to be done by physicians or other licensed healthcare professionals, and they have to be pulled from patient records to see and make sure that provision of services were done in compliance with clinical guidelines or standards of practice. So during the site visit, reviewers actually look to see what your peer review policies are. They'll look to see that you have documentation that peer review was done, but they also want to see that these peer review results and assessments were shared with the board. So for these assessments, you should document this in your QIQA committee meeting minutes, and then generally not physician specific, or you don't put any identifiers in it, but you should document that they were done in any general results, and then those QIQA minutes should go to the board. So the PAL also requires you to upload the most recent report that was provided to the board and staff. It must be from the current year or previous calendar. And then you also have to upload board minutes showing that this report was shared with them. For QIQA, the FQHC can determine who the person in charge of QIQA is. It could be an employer contract, full-time, part-time, and this person could hold other positions within the health center. Now, the person in charge of QIQA doesn't have to be a clinical person, but the QIQA assessments or the peer review must be done by clinical staff. So again, as last year, you had to upload the QIQA director's position description. And with respect to the 3 bullets under this heading, those 3 duties must be listed on the position description. And the position description also has to state that QIQA activities are part of the individual's daily responsibilities. Like last year, health centers will have to indicate yes or no whether they have implemented a certified EHR and that you have systems in place to protect confidentiality of patient records. Governing board requirements. I mean, those are a few. If you're subject to an FTA site visit, they'll talk to the board separately, and they'll want to know that the board is fully aware of your QIQA plan, that they're really informed of the activities that have been implemented related to QIQA. They'll ask whether the board has received regular reports. So board involvement is really key. And also the compliance manual requires that the QIQA policy be reviewed by the board at least every 3 years. So with credentialing and privileging, not much has changed from last year. You're still required to upload your credentialing and privileging procedures and policy. If any procedures are missing from what's located in the PAL, then it'll be interpreted that the health center is not implementing all of the components. So like last year, there's 3 categories. Oops, excuse me. Sorry, here we go. So as in last year, there's 3 categories of personnel that are required to be included in your policies and procedures. So the LIPs, OLCPs, and OCSs. And the OCSs are your unlicensed staff, if it's applicable in your state. So it could include medical assistants or dental assistants who aren't required to have any kind of license or certification. So the credentialing elements are the same. It includes verification of licensure registration, education and training, completion of the MPDB query, identifications, and basic life support. And basic life support is only applicable to those categories of staff that the health center has identified as who it requires to be certified in basic life support. So you could have a process or a procedure where only maybe physicians, NPs, and medical assistants are required to have basic life support, and that's fine. But whatever your process is or your procedure, you have to make sure that those staff have the basic life support certification. You also have to have privileging process. Excuse me. I'm fighting with a tickle in my throat.
Let me just jump in for 1 second. I just want to clarify that again now during the COVID process, there has been a significant loosening of credentialing and privileging requirements. So if you need to get new people on to start providing care, you don't need to worry about going through the whole process that normally would take you 6 weeks. You could give them emergency privileges, and most of the requirements are waived. There are also, in many states, I should mention nationally, CMS has basically said that any provider who is licensed in any state can work in any other state and still be able to bill Medicare and Medicaid. Of course, many of the states, you still need to worry about state licensure requirements, and therefore, if your state has not issued a waiver, you would not be able to do that. But many states have issued waivers allowing providers who are licensed in any other state to practice in their state. In some of those states, that applies to treating any patient, and other states it only applies to treating patients as it relates to the coronavirus.
Okay. With privileging is just a review of their competence in providing the services. So privileging elements include verification of fitness for duty, their immunization and communicable disease status. For initial privileging, so when you're first bringing someone on, you could verify their competence through training, education, and if available, references. For renewal of privileges, so after they've been there working for you for usually 2 years, you can verify current clinical competence through peer review or other methods, including a supervisory performance review process. And then your policy also has to outline a process for denying, modifying, or removing privileges based on clinical competence or fitness for duty. So you have to test that you maintain files with all the credentialing and privileging documents in it. And also, if you have contracts with other providers or written referral arrangements, your contracts have to include the language in the 2 bullets noted below that heading. So HRSA actually comes in and looks at your contracts to make sure those words are actually in your contracts. So just a note, again, you're not required to employ your clinical staff. You can have contracts with providers or provider organizations, except that you have to employ your CEO or project director. Other compliance manual requirements for credentialing, privileging. You have the flexibility to determine who has approval authority. So you can have your board approve, let's say, the LIPS, and have the CMO or medical director approve all others. Or you can have the medical director approve everyone. As a result of the site visit, HRSA, the reviewers did note that they want the board to at least be aware of privileging granted to clinical staff, even if your board has delegated the approval authority to someone else.
Right, but just keep in mind, just keep in mind that your state may have different rules. Some states, by virtue of you being licensed by the state, require that your board do some of these activities. So you just have to keep that in mind. What we're talking about here is purely from the federal HRSA level.
Right. Yep, good point. So, and you can determine how credentialing will be implemented. So you can contract with a credentials verification organization, or you can have your own staff or HR department conduct the credentialing activities. So for claims management, not much has changed from last year. You have to attest that you have a process for addressing claims, and the process has to include preservation of health center documentation, so putting a litigation hold for any potential claim or complaints to make sure that you're preserving the records, and that your process has to include working with the Office of General Counsel and making sure that any service of process or summons received is promptly sent to them. You have to upload documentation of your process, and you have to make sure that it includes those 2 bullets above. If you've had any claims during the past 5 years, you have to include specific details about the claim and also provide a summary of your internal analysis and activities taken to prevent future occurrences. That's only for closed claims. They don't want you to provide your internal analysis for open claims. You also have to upload the position description for the claims manager. And like the other job descriptions, it has to clearly say that claims, whatever the duties are part of the individual's daily responsibilities. So for QI, the position description had to say QI is part of the daily responsibilities of the individual. Same for claims manager. The application requires you to attest that you inform patients using plain language that you're a deemed federal employee. And the FTCA PAL gives sample language to use, and we just recommend that you go ahead and use HRSA's language as the notice. And new this year is that you have to include a screenshot of the exact location where it's posted on your website, if that's how you're proving that you notify the public. Okay. With respect to volunteers, so health centers may be using volunteers more now because of the COVID pandemic, but one thing that you should be aware is that just because you're deemed under the FTCA doesn't mean that your volunteers are deemed as well. So every year you have to submit a separate deeming sponsorship application for your volunteers, and the application is specific to that volunteer. So it's not a blanket application for every volunteer you use. It's specific to an individually named volunteer. And you could submit this at the same time that you submit. It's a separate application, and you could submit it at the same time as you submit your own deeming application. So there's certain requirements to be met in order to qualify. The FQHC must be deemed itself, and then the service must be in scope. The service that the volunteer will provide must be in scope. The FQHC has to sponsor the volunteer. The volunteer cannot be compensated for his or her services, but the health center can still bill for those services.
Okay, so we only have 2 minutes left. I will just say that the volunteers have become much more important nowadays, because if you have people who want to come volunteer in your center, they will not have coverage unless you separately apply for them. And so if you have people showing up, make sure that either they have their own malpractice insurance or your state has issued an immunity, or that you go back and speak to your project officer about getting them a volunteer coverage. Our understanding is that there might be an expedited process for it, but otherwise you will not be they will not be covered. You still will be covered, but they will not be covered for what they do. I just wanted to mention two other things briefly. Number one is many FQHCs now are providing services off-site. So if you're doing it in your parking lot, or you're doing it on your dental van, or someplace like that, or you're doing it in patient homes, or in a hospital, again, those are okay in terms of you don't need to go get approval from HRSA to be able to do that. However, if you're opening up a new site, which was not previously there, even though it's only going to be temporary, you do need to go back and get HRSA approval to add that site, or otherwise you will not be able to have that site treated as an FQHC site or have FTCA. Also, on a completely unrelated point, on last week's webinar, we talked about telemedicine and some funding sources that are available. There is another funding source for FQHCs which came out in the last day or two that people should be aware of, which is you can go to your Medicare carrier, whoever pays you for Medicare patients, and ask for an advance of up to 3 months. Like, they'll go back and calculate. Normally, each month they pay you $100,000 for Medicare. You could ask them to give you an advance of 3 months, which will then be recouped after that over a 4-month period, but that could help you with your cash flow purposes. Also, I don't know if we had many people who listened yesterday to a webinar we did about employment-related rights, and the new FMLA under the new Corona Act, the federal act. There was an exception that allows people to take 10 weeks off for Corona if they're taking care of their kids. The federal government clarified that for healthcare providers, anyone who works for you, even if they're not actually a provider, secretary, whoever, is considered to be carved out, meaning they do not have the right to take that 10-week leave without your permission. You would have to agree for them to be able to take it. And there are also, which will apply to most FQHCs, there are also SBA, Small Business Administration loans, which are available where you can borrow up to 2.5 times your monthly payroll, and you can then use it for payroll purposes and rent purposes and utility purposes, and anything you use for payroll, rent, and utility purposes will be forgiven. Even though it was a loan, it'll actually be forgiven, so you're getting free money from the government, with the caveat that if you have employees who make more than $100,000, then their salary above $100,000 you will not be able to use the money towards that. That's a lot of information I just threw at you in a minute, but if any one of you want to know more about this, because this could significantly help with your cash flow, like I said, essentially, you get the federal government to give you 2 months of payroll for free. Please feel free to reach out to us and we can give you the detail around it. Thank you to everyone for listening. To the extent there were questions, we're sorry we didn't get to it. We will respond to the questions outside of this. And like I mentioned, the presentation as well as the slides will go out in the next day or two. We thank you for listening. Have a good day.